Good day, friends, and a warm welcome to the third episode of 4D Season 3.0. 4D means detailed discussion and dialogue in diabetes, in Indian diabetes, by the people who take care of our fellow citizens. And this is Season 3, still going strong. This is our third episode. Now, the power of 3, that's a very important power. So let's welcome 3 very powerful, very passionate, and very pleasant people. And they're all from the city of Pune, a very pleasant city. A warm welcome to Dr. Tanmay Kulkarni.
Hello, thank you for having me here. Very much excited for this session.
The pleasure is ours, Dr. Tanmay, and to introduce Dr. Kulkarni to everyone from across the country. He's a consultant who works at Jupiter Hospital in Pune. And it seems when you read his CV, he won all the gold medals there were to win during his DM and before and after. So, Dr. Tanmay, did you leave any gold medals for the girls who studied with you? Or did you get all of them? You took all of them?
It's very kind of you to say that, but it's just practice. Practice is just more than the gold medals, and we all know that. Yeah.
Everything is required. So that balance, that wonderful balance of education and practice, and also a wonderful balance that you see here, expertise and humility. That's a wonderful balance that very few of us are able to carry into practice. So thanks, Dr. Tanmay, for being with us. We'd also like to welcome Dr. Ragini. Thanks. Dr. Ragini is an endocrinologist trained in the UK, and she works at one of our most prestigious hospitals, Chelaram Diabetes Institute in Pune. Warm welcome, madam.
Thank you, and good evening to all.
Thank you. Chelaram Diabetes Institute is known not only for good quality service, for good quality patient care, but also for education. And you try to reach the unreached. You try to reach each and every person who works in diabetes in India and beyond. So thank you for that.
Thank you very much for that, for those kind words. And it's nice to know that the effort we put in does translate into good knowledge across the country.
It does. And to complete the troika, so that's the power of 3, we have Dr. Swati Maniam. Warm welcome, madam. Dr. Swati is a nephrologist, also at Jupiter Hospital in Pune, and a DM from the prestigious KEM Hospital. She also has a fellowship in renal transplantation from CMC Vellore. So warm welcome, madam.
Thank you, sir. I'm very excited to join this session.
I'm even more excited because Pune is one of my favorite cities. And what I like best about Pune, someone may say they like the food, they like the music, they like the ambience. But what strikes me most is that there is a roundabout which just has a book. So it's a roundabout that worships books, it worships education. That you don't see in most parts of the country. Though in Karnal, where I live, we also have a book chonk. We call it a Ved chonk because it's 4 sides, and on each side they've written the Rig Ved, the Athar Ved. So they've written all the 4 names of the Vedas. So that is what we worship as well. But talking about worshipping education, all of us who are gathered here, who are listening to you, we have this in common. We are educated, but we are still hungry for more. We want more education. And then this balance that all of you bring, this, and what I like the most, this is speaking to everyone who's listening to us, this humility, this down-to-earthness, in spite of having the best degrees from the best colleges in the world, that is something exceptional. So, but let's ask a question. It's a googly, Dr. Tanmay. Would you like to go first?
Yeah. Why not?
Yeah, and when a question like this is asked, so the tone is yes, we are asking you to volunteer, but it's involuntary. So the question is, what do you think of astrology? Do you believe in astrology, Dr. Tanmay?
Yeah, I do believe. It's also a science, just like any other modern science. It is also a science. So of ancient India and how beautifully it predicts many things. So definitely, I do believe, but not to the 100%. But yes, I do have some interest.
And Dr. Ragini, you studied in the UK. Do you continue to believe in astrology?
So I think linking it to the topic that we are discussing today, I can see how you're bringing it in. Prediction is as good as the data you put in. So it depends on whether you've got the coordinates right. So your birth time and then the position of the grahas and everything. And so I believe in it as a science, as Dr. Tanmay said. However, I've For example, I've got 3 kundalis made, and all 3 of them say 3 different things. And so, but then the same birth time and everything was provided to the same people. So I do believe in it as a science, but in terms of how much blind faith I can put in it is perhaps difficult to say.
And Dr. Swati, the same
So,
question.
personally, I don't believe in astrology, but as Dr. Ragini said, as a science, yes, means I would like to know more as a science, but personally, I don't believe.
But there is a role for astrology, and why do people believe in astrology? Why do people go towards astrology? Because everybody wants support. And one kind of support that they want is they want prediction for the future. So, of course, no one can predict what's going to happen a second from now, whether our internet will be working or not, whether our Wi-Fi will support us or not. But still, people get comfort, they get solace in the future. And so many times when patients come to your OPD, they have one question: Sir, will I be able to go off insulin? Sir, will I live for the next 20 years? You've put in a stent. What will happen? Madam, you are telling me to go on hemodialysis? I agree, I believe you, I obey you, but how long will I last? So that is the kind of astrology that they seek from us. Now, Dr. Tanmay, in cardiology, how good are you at predicting the future? Can you predict whether someone will have an MI in the next 1 minute or not?
So not exactly, but yes, probability we can tell, but not exactly predict.
And Dr. Ragini, in the diabetes arena, can we predict glycemic future?
So there are certain indicators that we use, like insulin resistance. How likely is a person to be insulin resistant versus maybe a thin individual who's more likely to be insulin sensitive and deficient. So there are certain indicators that we can use, but do they always serve us right? I'm not so sure, because we have so many examples, particularly in India. So you mentioned about being in the UK. So it obeyed those principles much better in the UK, but when it comes to Indian population, distinguishing between the insulin deficient and sensitive person versus the insulin resistant obese person is not as accurate. But yes, there are certain, and we're guessing all the time. We do try and make predictions and choose the best treatment for our patients at work.
And Dr. Ragini, from the UK, we have these wonderful risk tools. For example, QRisk which tells us about So or we have Frax tool, which we have in India as well. Do these work in practice, and how frequently does the general practitioner in the United Kingdom use these tools?
So I think there are in the UK we have certain protocols and guidelines. So NICE guidelines or these tools, whether that's the general practitioner or whether that is the specialist in clinic, we do tend to use them without Frax. For example, you wouldn't justify. So when your practice is audited, if you're not following guidelines and you've not used the Frax score or you've not used the QRisk score, that would come down heavily, and then you would have to review your practice. So yes, it is used much more frequently, I would say, in the UK.
And these were RIF tools.
Yeah.
Sorry on that.
No, I was just going to say that the risk tool didn't apply to diabetes patients. There was some difficulty in applying it, but certainly there were discussions around it.
Yeah. And these risk tools serve as a modern form of astrology. They can be used by the patient. So you can tell the patient, yeah, this is the probability of your getting maybe a vascular event, or in Frax having a fracture, and this is how you can work around it. Of course, there are some things that are non-modifiable, but then other factors are modifiable, so we can work on them. Dr. Swati is with us, and one of the most organized specialties in internal medicine is actually nephrology. So, madam, the KDIGO people, have they been able to create their form of astrology?
So there are some risk scoring or tools are available which can predict, for example, the acute kidney injury in a ICU patient or acute kidney injury in post-CABG or post-cardiac surgery patients. and they have included some new biomarkers in that, which can definitely predict the development of acute kidney injury before the creatinine starts actually rising. So yes, in nephrology, there are some predictive prediction tools which can help us to diagnose early AKI or predict the progression of chronic kidney disease or development of diabetic nephropathy or diabetic kidney disease in diabetic patients.
And Dr. Tanmay, if we take this to the cardiology OPD or the cardiology indoor setting, then machine learning, artificial intelligence, these are gaining ground everywhere. Some people say that machine learning and artificial intelligence will replace all of us, though I find it difficult to figure out how the machine will be able to sort of maybe do an angiography or an angioplasty without your support. But still, how important is AI now in cardiology? And let's focus especially on risk stratification and risk prediction.
Yeah, absolutely. AI is coming to medicine in a big way, and of course, cardiology is a specialty which will be engulfed by AI soon in a good way. Because see, being a cardiologist, um, for example, patient comes to me, I have to analyze, take history, read ECG, do echo or read echo, then all the other things, blood tests and all. So if AI is there, and because we feed almost everything to AI, so AI can definitely predict that, or give me some basic summary that this patient is coming to you and his ECG shows this, his echo shows this, these blood tests are like this. So this will be very easy for me to interpret, and finalize the protocol treatment for him and diagnose also, because for echo I'm busy in OPD and echo is done by technician. I don't know how much exposure he has got in his training, how good he is in picking up a few things. He may miss few things. AI less likely to do that because we have fed the data to AI almost everything whichever is available on the web. So definitely I'm waiting for this day that AI will give me the summary that this patient is coming to you, his ECG echo is showing this, and blood tests are like this, and I think this is the plan. I'll just approve and I'll finalize things, and I'll do the best possible next step.
There is a question coming for you, Dr. Tanmay. This is from a physician, Dr. Carrot in Miraj in Maharashtra. And she says, Sir, when we read the ECG reports, is that also a form of AI? I get a printed ECG and on the side it is written maybe left axis deviation or sinus arrhythmia. Can I trust this blindly or do I still need to consult a cardiologist?
So this is not AI, but it is, we can say, very preliminary form of AI, that machine reads the ECG and few it comments, but we cannot rely on that at all. And that is not for physicians or that is not for a cardiologist. I strongly believe this machine interpretation is for those who are in the periphery. They don't know how to read ECG, and to guide them whether should I send this patient to higher center or to a physician or to a cardiologist. This is how we should take help of that machine interpretation, but definitely we should never trust it blindly. Many times I cut that interpretation and write my own, because that just is not, it does not make sense many times.
Yeah, but the point that Madam is raising is right, because that does help her decide when to refer to a physician or a cardiologist and when not to refer. And Dr. Ragini, we are speaking of AI and machine learning now. At Chelaram Institute, where you work, you are leaders, not only national but global leaders in harnessing technology. That is one very nice thing about Chelaram, that you are able to find and then you are able to utilize and then improve upon the best technology. So, what are the things that you are using now in cutting edge technology to help people with diabetes and people with complications of diabetes?
So, I'm not sure I can answer that question with confidence in some ways.
Like, for example, when you do fundoscopy and you're also short of manpower, woman power, how are you able to touch the villages around you for eye and for foot
Yes.
care?
Yes. So in our village screening programs, we do use technology in terms of screening individuals for diabetes, for screening for retinopathy. Not so much neuropathy. We were probably, I think, currently we're not using any tools as such, but we also had employed breast cancer screening more recently, where we used some technology in order to cover certain villages that we said. So I think, yes, in terms of population screening, utilizing the limited time that you have and untrained staff, we would be able to screen those individuals, bring back the data, and then run through whether the data interpreted is correct or not, so that we can identify disease or non-disease in that way, because one person can only be in one place at one time. Not this, and the specialists can't travel capabilities.
Dr. Swati, in nephrology, by default, by definition, you deal with high-risk patients. Everyone, of course, everyone entering a cardiology clinic or an endocrinology or diabetes clinic or a nephro clinic will be at high risk. But in general, the people in the nephrology clinic are the ones who have already got complications, and now we are working on tertiary prevention. We want to help them live a happy and healthy life, and we want to prevent them from getting worse. How important is AI for you in your daily practice?
So it is particularly important in critically ill patients. So like we all know, acute kidney injury diagnosis and management is challenging, particularly because heterogeneous nature of pathophysiology. So patient with infection can develop AKI, patient with cancer can develop AKI, post-surgery patient can develop AKI. So there will be variation in the pathophysiology and underlying risk factors. So AI can help to strengthen the currently existing prediction tools and can diagnose this situation quite early, so that we can make the modification in the treatment plan which might prevent the development of AKI or reduce its severity, and ultimately it can contribute to improved outcome. So this is about ICU, and other patients who are already on dialysis or visiting nephro clinic who are CKD on conservative treatment. AI can help to assess the additional risk factors and prevent the progression of CKD. So basically, the graph over the last few months or few years can help in the improved management.
One of the challenges I always faced as a physician, I've been in endocrinology now for 28 years, that is that I'm still not able to predict. Let's say I've diagnosed CKD stage 4 in a patient of mine. There are some patients who will remain in CKD stage 4 for 10 years. Nothing happens to them. And you keep on telling them to go to the nephrologist. They will say, sir, read Aesop's fables. And you know the story of Sher Aya, the lion has come, the lion has come, the lion never comes. Why are you troubling me? And then there are other people, maybe I diagnosed CKD stage 3B or something, and I just said, okay, doesn't matter, relax, and we'll keep you comfortable. And within 2 months, they have progressed so rapidly that they have reached CKD stage 5. And then I feel guilty. Why couldn't I refer them earlier to the specialist? So can AI help us in diagnosing or in identifying which patient is going to worsen rapidly and who is going to have a more indolent course in CKD?
I am not sure that whether it will differentiate who will progress very rapidly and who will not progress. But there are definitely some known or established risk factors which can contribute to progression. And sometimes in a busy practice, we might not look at all the risk factors carefully in each and every patient. So probably AI will make my work easier, and AI will tell me ki yes, he's taking some alternative medicine, or he's taking NSAID, or blood pressure control at home is not good. So when patient is coming, he is taking medicines, BP is normal, but home BP monitoring might not show the same result. So AI will bring out the signals or red flags in front of him, in front of me, and then probably it can contribute to treatment.
A colleague of yours sends in a message. His name is Dr. Saurabh Sharma, a nephrologist from Safdarjung Hospital, New Delhi. And he says that now we are working on using AI to predict which person can fast safely during the Ramzan period. And I guess this would make sense for people who keep the Navratri fasts as well. Because there also, if you have this AI, this machine learning, you can counsel your patient whether they can restrict fluids or solids or not for a long period of time. And this would be important for many people, especially in India, where our quotient of spirituality and religiosity is on the higher side. Dr. Tanmay, same question. Sometimes people come and complain of symptoms suggestive of unstable angina. In endocrinology, we ignore them. I say, you've got an acute panic attack, anxiety neurosis. Maybe I diagnose a hot flash, menopause. Perhaps I think it's because of hypokalemia. Hypokalemic periodic paralysis. So multiple reasons, or our favorite bugbear, that is hypoglycemia. Okay, the machine didn't show hypoglycemia, but you have hypoglycemia, you go and take some sugar. So we diagnose all these things, and actually it's an anginal equivalent that's going on. And finally, the outcome is that the patient reaches the cardiologist too late. We could have sent him earlier, we could have sent her earlier. Any role of AI in diagnosing these kind of patients and in helping us help the patient in a more efficient manner?
Yeah, so you're right. I think still AI may not do a good work here because being a medical trainee, whatever we learn the probability as per the symptoms. So and we do take into consideration the demographics, the age, and all these things. So then we come to the conclusion that this may be this problem, hypoglycemia, or anything else, maybe unstable angina. But currently, I think AI is not really that evolved to take these decisions. So I'm not really sure that how AI will help in this. But AI will definitely help us. If patient is having unstable angina, what probability is that he will have single vessel disease, double vessel, triple vessel, or as per the echo, as per long-standing diabetes or hypertension, cholesterol, all these things. So I really think it will be good to predict. But for diagnosis, I'm not really sure, because unstable angina is something which is too much of symptom based. Even if ECG is normal, even if troponin is normal, and we do advise admission and do repeat ECG, echo, troponins, and then CAG. So I think the way we are trained and our brain network is being trained in medical institutes after seeing thousands of patients, I don't think immediately AI will take that control.
Dr. Ragini, what Dr. Tanmay has said, this suddenly, throws open a totally new dimension, a much bigger dimension of AI. So something's coming to my mind. What Dr. Tanmay said, in endocrinology, we call it cognitive circuitry. So cognitive circuitry, and from a cardiology perspective, will be different. We have the same cognition. All of us have the same IQ. Any doctor would be in the same bandwidth of IQ, but the circuitry, the cognitive circuitry is trained differently, or is taught differently in nephrology, in cardiology, and in endocrinology. So we see the same thing in different ways. It is not similar. It can be very similar, but not the same. But Dr. Ragini, now see what Dr. Tanmay is saying. He's saying that the gatekeeper is going to remain human astuteness. You take the history first, then you feed the AI algorithm, and then the AI algorithm will help you predict. So the first step is taking a history. So in endocrinology, now compare, when we are doing universal screening for hypothyroidism or for diabetes, then our limiting factor becomes the quality of the TSH assay, the quality of the glucose estimation.
Yes.
This is what usually happens in cardiology and nephrology. The non-cardiologist, the non-nephrologist assumes that the cardio-nephro people are looking only at numbers. So the quality of care at Dr. Swati's center will be a direct correlate of the quality of the serum creatinine estimation. Just to take an example. Now, in
Yes.
endocrinology, we have a different kind of a field. Let us say we are treating late onset hypogonadism. The first thing is to take a history. If you feel that the history is suggestive, only then you do a serum testosterone and then you move
Correct.
forward. Can you think of other things in diabetes? Now we have to work in prevention, we have to work in management. Where do you think AI will not work in diabetes care? And where will that human touch always be there of history taking, of touching, of talking, of listening?
I think it will be there throughout, I guess, because even if you replace accelerometers with a lifestyle data which you can get from a history, you I guess in terms of feeding the family history, for example, you would need to get the accurate data from the patient. In terms of still distilling the information that you get, because AI models will improve with time, and their accuracy, their predictability will improve with time. But I still feel that you go to different doctors. Why do certain patients flock towards certain doctors? There are many more endocrinologists, and it's because there is that extra factor or X factor that an endocrinologist, perhaps like yourself, would bring to it, where you would recognize patterns that we experience as well attached to it, which AI algorithms may not be able to predict. There will also be the human touch. A person, at the end of the day, a person with diabetes distress, for example, would need a human sitting next to them and saying, yes, life is bad. Yes, your diabetes has not been good, rather than spew out a machine-based diagnosis and a management plan. And sometimes you will need that human touch. So it is predicted that human touch will also be replaced by AI, and there are Japanese dolls that people are buying to replace or to help people who feel loneliness in Japan. But I do still feel that emotion will be something that connects us to our patients, will not be as accurately reproduced by AI, I think, is what I feel.
Thanks a lot. And Dr. Swati, going to nephrology, is nephrology actually based just upon numbers? Because when we look at the algorithms in nephrology, if the EGFR is 30, you do this. If the EGFR is 29, you do that. So does it all revolve around EGFR and microalbuminuria, or is there a human angle attached to it? Do you look only at this?
I don't agree with this, that it is only numbers. So every patient will have different clinical presentations. So sometimes CKD stage 5 with creat of 8 will not have any symptoms, and sometimes CKD stage 3 with creat of 2 to 3 can land into fluid overload if they have underlying heart failure or other comorbidities. So management is definitely dependent on the. So what I would like to say, AI have no role in history taking. It cannot replace history taking and physical examination, which is very important part in diagnosis in all specialties. So I will give you one example that one post-transplant patient who got admitted for kidney biopsy for echograph dysfunction. And on day post biopsy day 1, he developed sudden onset of altered sensorium and involuntary movement of the limb. So in this patient had actually developed acute hyponatremia because of desmopressin spray, which was used prior to biopsy, as patient had a high creatinine to reduce the risk of bleeding. So history taking have very important role in diagnosis, which probably AI cannot replace.
Dr. Swati, what a wonderful example endocrine and nephro and cardiac or vascular interaction, and something that most of us would never think of. So, Dr. Agni, your comments on this. They used a hormone, they used it for a vascular purpose, and we ended up with a metabolic or a nephrological and neurological challenge as well. Any other unexpected drug interactions or drug effects that come to your mind? Anything that comes to your mind? You use a hormone for benefit, but you end up with a nephro or a cardiac adverse event.
I mean, in terms of endocrinology, I think steroids and diabetes or glucose deterioration in glucose control comes to mind. But in terms of nephro and cardiac, I suppose hormonally growth hormone excess can lead to it, but that's a physiological condition. So growth hormone excess can lead to cardiomyopathy. But I don't know if you have another example in mind. Suggest.
What came to my mind immediately was thyroid hormone, otherwise supposedly very innocuous drug. But the threshold that we would have for initiating thyroxine would be different in Dr. Swati's patients. And then again, the stage of CKD, whether they have renal osteodystrophy or not, that would be different. And in Dr. Tanmay's patients, if somebody has heart failure or somebody has, let us say, unstable angina, suddenly our thresholds will vary. They may go up, they may come down, but there will be changes everywhere. Yeah. So which means even when you want to start thyroxine, you need to take a very good cardiac and a very good nephro history before deciding whether to start or not and what dose to start with.
Yeah.
Dr. Tanmay, this patient that Dr. Swati mentioned, hyponatremia, would any AI have caught it in your ICU? Who would be the first person to catch it? Would it be the laboratory technician who brought out the number 124 sodium? Would it be the nurse, the ICU in charge? Would it be you when it came for rounds? And how can we, wherever we are in India, whatever we are doing, how can we use AI or modern technology to improve our quality? We have a patient with sodium 124. The report has just come from my hospital lab. What can I do? How can I use technology to make things better?
So very interesting question and very relevant in today's era, because what I really think, everyone is facing the same issue. I'm sure in ICU, the real scenario of hyponatremia is like patient before symptoms also. If the report shows, that is the first thing. I think so, because if there is a resident of or there is some ICU doctor, he will show the report first rather than telling me the symptoms. And if it is not getting explained, the symptoms, the neurological symptoms, for example, then sodium will be checked. So both wise, but I really think practically, resident will tell me that sodium is low rather than telling me he is having drowsiness or he's having some neurological symptoms. So because we really, AI cannot, no one can sue AI in the court currently, so everything will be on us. So should we really trust AI that much or not is a really currently confusing decision. And AI should be used only for non life threatening decision making or just a routine analysis is what I really think.
That point is also well taken. So when you are dealing with great numbers, then you can rely on AI that might help you do a triage. And that also, of course, may not be 100% accurate, but still it will help you do a triage. For example, Dr. Tanmay has to see 20 patients in the ICU. Which patient does he go to first? AI might at least help you with that. Which patient do you take now first? Dr. Swati, we face this problem, and another, again, a comment from Dr. Saurabh, where he says that now we struggle with electrolytes. So there are some drugs that we use in cardio, in nephro, in endo, where there is a risk of hyponatremia. There are others that we want to use, but there is a risk of hyperkalemia. And then we are always struggling, trying to balance, trying to keep our patients in the Goldilocks zone. So speaking specifically about electrolytes and about dyselectrolytemia, what do you think are the shortcomings in our current practice? And how can modern technology help us improve our quality of care?
So sometimes we know when we start for example, in CKD or CKD with proteinuria, we want to start ARBs or ACE inhibitor, and patient's potassium is already borderline. So in such patient, we know that after starting ARBs, patient can develop hyperkalemia. So monitoring is important. So AI might help us regarding the trend of the electrolyte, which it can keep in front of us. And again, I'm not sure, because unless patient is aware of it, he can develop such problem and go and check the blood sample in the laboratory. How AI will help in this matter if it is a OPD basis patient. But definitely admitted patient, the trend of the electrolyte, which sometimes we or our resident doctor or staff can miss, can tell us the patient is going down, down, down. So, for example, on admission, sodium is 140, and slowly it is 138, 136, 132. So sometimes we might miss, but trend can definitely tell us.
This concept of trends is also nice. So, Dr. Ragini, when we are treating diabetes, maybe type 1 diabetes or even type 2, and then we are also worried about hyperglycemia, what are the common tools that we can use now to monitor not only current glucose but also trends in glucose and then predict them? And is this only diagnostic, or does it have a therapeutic angle to it as well?
Yeah. So diagnostic, yeah, but therapeutics certainly we've been using for a long time now, whether that is continuous glucose monitoring, which we now have sensors that can detect a drop in glucose level. So there are arrows, and then there are, so that the patient can be alerted by looking at the arrows and the direction of the arrow as to whether the glucose is coming down slowly or whether it is coming down rapidly. So that's definitely made a difference to patients' lives, quality of life, being able to detect and avert a hypo. Certainly, in using insulin pump technology with the help of AI, if there is a detection that there are subsequent, say, for example, if the glucose is rising, then additional insulin is delivered by an AI algorithm. And similarly, if there is a detection of a drop in glucose level, then the insulin dose can be suspended or insulin infusion can be suspended. So it has definitely made significant difference to patients' lives, at least in glucose monitoring for sure.
Any examples, Dr. Tanmay and Dr. Swati, from cardiology, from nephrology, where, like, for example, now we use we use glucose monitoring devices, and then we use insulin pumps, which are intelligent insulin pumps. They're able to handle on their own. So any examples from maybe heart failure management or maybe arrhythmia management in cardiology? And then nephro, Dr. Swati.
Dr. Sanjay, I really did not get the question. Can you please repeat it?
So we are talking about the role of technology, and we have found that we realized that artificial technology helps us in diabetes. We have very good quality glucose monitoring systems now. We call them ambulatory glucose monitoring, and that is diagnostic. The same way that in cardiology you would do a Holter or a 24-hour blood pressure management. But we have been able to take that one step extra. It's not only diagnostic, it's theranostic, because when you attach that system to a pump, then the pump itself figures out that the patient is going to get hypoglycemia, so they stop the insulin or they reduce the dose. The patient is going to get hyperglycemia, so they increase the dose on their own. So any kind of system in cardiology where there is a therapeutic angle to artificial intelligence.
Okay, great. So, so AI, for example, if we take smart watches like Apple Watch, so these Apple Watches, they are making a big difference, because especially for the cases of atrial fibrillation or ventricular tachycardia. So the patients who are post MI, they're developing some kind of lightheadedness, dizziness, not really syncope, not really fall or LOC. So these are very good. Smartwatches are very good to diagnose. So we are using smartwatches a lot for especially people who are having AF. I recently remember last week I had young lone AF patient. So he said, "What should I do and how should I confirm? I cannot run everywhere, but to diagnose my if I'm having frequent episodes." So he bought Apple Watch, and the next day he sends me ECG. He's having a for 10 seconds, something like this. So we are using all the possible options to diagnose and treat, because then I gave him flecainide. I told him that you take flecainide. You are having already in the pocket. Take these 2 tablets. So this is how. It is we are using it also. And there are some portable ECG machines who are these machines which are smartphone based, app based. So we are using it, especially when people are going for hiking or some periphery where there are no networks, but some Wi-Fi will be there nearby, and they can use this smartphone based ECG if someone collapses, if someone is having chest pain. So yes, this interpretation by AI or AI related the new techniques, we are using it regularly for diagnosis, for treatment. So definitely it will come in a big way in coming few years.
So you've mentioned about arrhythmia management. Is there any role of such devices in heart failure management, heart failure prevention?
Yeah, so heart failure, immediately understanding the heart failure is difficult, because heart failure is a clinical syndrome. It is not just NT-proBNP, not just ECG, not just echo showing low EF. So the definition is it's a clinical symptoms and signs of heart failure. So AI immediately cannot predict it, but rhythm, for example, if you understand patient is having unexplained tachycardia, even if it's sinus, patient is having some breathlessness, we can predict might be heart failure, and we can ask him to come here. And now the new pacemakers, because heart failure people will have CRT or CRTD, all the Bluetooth enabled or wireless tracking is possible. Then we can sense it what is happening, and then we can just call patient to ER.
And Dr. Swati, any scope for using such technology in nephrology?
So, in terms of prediction, diagnosis, yes, but I don't think in terms of therapeutics, like you mentioned the example of insulin pump, which automatically gets stopped if there is hypoglycemia. I don't think it is existing in nephrology. But definitely, there are some examples like in dialysis, or particularly in critically ill patient who is on CRRT. There are some auto mechanism and alarms which can tell us if some problem is happening. But I don't think in therapy there is any role of that.
When I was a MT student, I trained in nephrology. So I was posted in nephrology for 2-3 years. Our hemodialysis machines, I remember, they used to look like the computers of 70 years old, and we used to struggle with simple things, hypotension, hypokalemia. I mean, it used to be such a torture for the patient. Of course, it was a torture, but for the JR and the SR on duty, getting a hemodialysis done used to be a bigger torture. Is this true now that we have hemodialysis machines which will predict fluid status, which will predict electrolytes, and which can become faster and slower on their own, just the same way our insulin pumps do?
No, not on their not on their own. So again, it is not going to replace our clinical judgment. So there are some techniques which can guide us, but it cannot replace. And they will not adjust the UF rate on their own. There are some mechanism which can prevent the air embolism, and automatically machine will get stopped if there is air in the circuit, or if there is any clot, it will give alarm. If pressures are abnormally high, then it will give us alarm. Then we have to go and find the solution and diagnose the situation.
So we've had a great discussion today, and we've learned from our experts how AI can be used. We began with astrology, and all of us have different opinions about astrology. Irrespective of what those opinions are, we cannot escape. Astrology is an integral part of being an Indian, of living in India. It has its strengths, it has its shortcomings, and maybe there are opportunities. Today we've spoken about the power of three with three powerful, pleasant, and as you can find, very productive people. But let's conclude with three questions, and we'll ask all our experts the same question. So our question will be three strengths of artificial intelligence and machine learning as we go forward. We'll ask all of them this question. And then our next question will be three weaknesses of artificial intelligence. And perhaps we can conclude with three opportunities. In your field, what do you feel the opportunity is? What are researchers working on? So anyone who would like to go first? Dr. Tanmay, voice first. Three strengths of AI in cardiology.
Yeah, so interpretation, extract data, uh, and the diagnosis in few places. I think that will be game changer.
The strength. And Dr. Agni, same question from a diabetes window. Three strengths of AI.
I think as much as we say that there is a human element that actually sets us apart and we can do a bit more than machines, I think sometimes the human element can let us down too. So on a bad day or in a busy OPD. So the variability that we might experience, I think AI might be able to give us consistency from patient to patient. But I think in terms of accuracy, in terms of efficiency, because sometimes we may have a slowly working brain, and whereas AI may be more efficient, it is also more efficient at processing larger amount of data, provided the data has been fed to it properly, of course. So this is all given that it's an ideal AI based system. So I think efficiency in terms of accuracy, and this has been shown that for example, in radiology, AI-based systems are better at predicting micro fractures or hairline fractures than humans are. So there are certain things that AI will definitely add an edge to sort of in reducing the variability, in increasing the efficiency, and perhaps improving accuracy once the sensitivity and specificities are better when it has been fed more data.
And point well taken. We struggle a lot with variability, whether it is glycemic variability or barrow variability, that is weight, these ups and downs. The colleagues in cardiology, they struggle with heart rate variability. Too little is too bad, and too much is also too bad. So you need something in the middle, in the Goldilocks zone. Now, Dr. Swati, three strengths for AI in nephrology.
So in nephrology, I think prediction of acute kidney injury, AI will have definitely a big role, particularly in critically ill patient. Then it can forecast the progression of the disease, particularly CKD. And sometimes I think particularly in cardio-renal syndrome, the patients with the cardiac situation who have a high risk of developing AKI, the AI might have a role. Other than this, in treatment and therapeutics, I am not yet convinced that AI will happen.
So thank you. So we see different opinions from different specialties. So going forward, we have spoken of strengths, but let's talk about weaknesses. Dr. Tanmay, what do you feel are the weakest points? Where will a human cardiologist always score over an artificially intelligent cardiologist?
A real cardiologist can be sued by patient and will be presented in the court of law. So that is one drawback, you can say. Second, real world data is still not available. It's lacking with AI.
Yeah.
So that is one thing I think so. This is the second problem. And third problem is AI is good for basic analysis, but it is not for that. What we have learned, we have come a long way in medicine with so much of training, specialty, subspecialty training. I think AI will not do that thing, at least initially, in next 20 years at least.
And Dr. Ragini, any weaknesses? Again, glucose control
Yeah.
perspective.
Yes. So what AI won't be able to replace is hard data. So in terms of whether that is glycated hemoglobin value, whether that is a blood pressure measurement, whether that is a lipid parameter, so actual information that is there for that time point. So AI won't be able to produce that value for us. It may be able to estimate it, but not produce the real value. It won't be able to, I think, predict perhaps whether a patient is going to be concordant with his treatment. So treatment gaps are some is some of one of the things that AI won't be able to predict. The other thing is, I think a lot of the times we are struggling with AI models and its adaptability, as Dr. Tanmay said, is because it is studied in a certain patient population, and you then apply it to a different patient population. It's like the sort of, will GLP-1 analogs work as effectively in Asians as they do in Caucasians? Yes, now we have research evidence, but if we were to employ an AI-driven model, we wouldn't know because it wasn't fed the data about, or enough data about Asians. So in terms of being able to generalize one data set to a different to a different population, we may still struggle until there's a large amount of data set that represents the patient population we want to apply.
Thank you. And Dr. Swati, you already talked about the limitations, but any specific areas for improvement, where do you feel we should focus on, or what changes will occur in nephrology in the use of AI?
So we don't know whether use of AI will improve outcomes. So I think trials are needed, research trials, that whether use of AI have improved the clinical outcome of the patient. Second, like Dr. Ragini said, so use these AI models which are prepared in other countries, and we are applying it in our local population. So local validation is needed to apply here, and I think these are the 2 points which we need to improve.
So we've had a great discussion so far, and suddenly all of us, we are very much enriched. We understand how things are changing now. The entire ecosystem is changing. Artificial intelligence is becoming part and parcel of our lives. But that doesn't mean we should allow AI to rule us. We should have a balanced approach towards AI. Like Dr. Tanmay, Dr. Ragini, and Dr. Swati said, there are strengths, there are opportunities, but at the same time, there are limitations. And perhaps if we can use AI as a tool, instead of allowing ourselves to be governed by AI, that would be the best way forward. AI will help us become more efficient, more effective, but we will always need that human angle of being a doctor. I think that is what keeps us going, all of us. So these are environmental challenges and environmental hazards that you face when you're a doctor in India. But then there must be something in the profession that keeps us going, something extra, something special, something unique, something intangible, something that you cannot say in words, something that you cannot write on paper. So what is that happy thing, that unique thing that keeps you going? Let's ask all ourselves that question, and feel free to share your comments with us. We'd like to conclude today. We thank you for being part of 3D. Like we said, this was the 3rd episode. But before we conclude, we'll wait for your answers through the 3D team. What is it that keeps you going as a doctor? What is it that you find most special, most empowering, most energizing, most enthusing about your profession? And let's conclude with that one word from each of our experts. So Dr. Tanmay, you've always been going first. Let's keep you last so that we have more time to think. Dr. Ragini, what is it that keeps you going as a doctor in India? A single word or a single phrase?
Patients. The interaction with patients.
So the human touch. Thank you. And Dr. Swati, would you, let us say you don't believe in astrology, but supposing you were to get 7 more lives, would you want to be a nephrologist again?
Yes, definitely.
What is it? What is that single thing which makes you say yes?
So happy patients after transplant, I would say.
Yeah, so happy nephrons. Yes, that is something that we have. And Dr. Tanmay, so matters of the heart are best left till the end. They are usually best left unsaid. But here, one word from your heart. What is it that you love most about being a doctor?
So as this is the AI discussion, so I'm happy, and what keeps me going is AI cannot give sympathy or compassion which I can give to my patients. So that keeps me going.
So I think being human, that is the common theme or the common thread that all of us have. So let's celebrate being human. Let's celebrate being part of humanity. And let's go out and do our best for the human beings who come to us seeking succor, seeking help, seeking support as well. And on this very happy and humane note, I'd like to say thank you and Jai Hind. Wishing you all a great festive season ahead. Keep tuned into 4D. Yes, Dr. Agni, please.
I was just going to
Yes,
say
ma'am.
that it has been an enlightening and a very enjoyable session. Thank you, Dr. Kaldra, for leading this session in a very conversational way. So thank you very much for that. And I just wanted to end with a bad joke that we've all learned about iatrogenic disease. We are now learning about iatrogenic diseases.
Yeah, iatrogenic, and we all need to be aware of that. Thank you so much, madam. Thank you, Dr. Tanmay. He has left. Dr. Ragini, Dr. Swati, thank you so much. And to everyone who is logged in with us, tune in again next week. Yeah. Jai Hind.